I'm Joe Augustinelli, Social Media Manager at Greenway Health, and this is Putting Possibility into Practice, the podcast from Greenway Health. And on this episode, I am joined once again by David Heller, Corporate Counsel, Regulatory Affairs here at Greenway Health. As you may know, David has been a guest on this podcast before. We appreciate him taking time out of his always busy day to join us for this episode as we discuss the first half of 2018 and looking ahead to 2019 in the regulatory season. And I welcome David to the show. And first, David, it's been a busy first half of the year, and why don't we discuss some of the recent changes, and then we'll go through in detail what each one means for providers.
Most recent thing that's come out is the proposed rule for the Inpatient Prospective Payment System, so IPPS. Quick thing to clarify, the IPPS governs really Part A of the Medicare schedules, so here we're really talking about hospitals and facilities. There is relevance to the ambulatory space in terms of what we think might happen in the physician fee schedule. The proposed rule has some really notable things in it, I think, that will apply for most folks when the physician fee schedule comes out. So there's this redesign of meaningful use and the creation of promoting interoperability. There's a really big focus on burden reduction for providers. The administration has been really clear that's one of their key objectives, and tied to that is how they're looking at quality measures as well. So there's lots of meat in there for different folks, and it is somewhat predictive of what we expect to happen in the physician fee schedule. So when we look at the policy things driving the redesign of meaningful use and the policy decisions around the removal of different quality measures, it gives us an indication of the same policy considerations that could drive the physician fee schedule.
And let's discuss the recent proposed rule for Inpatient Prospective Payment System and what it may mean for providers. And when we talk about proposed rule, maybe we just want to touch on a little bit what goes in now to the process that it's proposed. What's next in that process?
So whenever a rule is proposed, it's left open for comments. The period usually depends on the rule. This one will end the comment period at the end of June. CMS will collect all of the different relevant comments from interested stakeholders. So here we're looking at providers, hospitals, facilities, EHR developers like us. And then CMS sits on those comments and considers them for a matter of months and incorporates them into a final rule. And that final rule is then issued usually in the late fall of the same year. And then that rule is implemented on January 1 of the following calendar year.
And what should providers be on the lookout for in the Inpatient Prospective Payment System?
If you're a hospital or facility, the answer is going to be a little bit different because that's your entire essential fee schedule. If you're an ambulatory physician or in the ambulatory space, what I would be paying attention to is the meaningful use redesign, because there's a strong chance that goes out into the physician fee schedule. So first, they've taken meaningful use and renamed it to promoting interoperability. And that name change is already showing up in different CMS documentation around the Merit-Based Incentive Payment System, or MIPS. And outside of just changing the name, they've made a couple of substantive changes. I think that will impact provider strategies for participating in promoting interoperability. Specifically, they have changed the measures that have to do with querying or looking around for summaries of care when a patient is transitioned to your care setting. So previously, you were asked to proactively query other systems to bring patient records in. Now it's become more reactive, where if you receive a summary of care from another provider or care setting, then if you reconcile that summary of care into the electronic health record, you receive credit. So it's making it more of a reactive measure base than a proactive one. And the purpose here was to try to really reduce the burden on physicians and care providers in the hospital and facility space. But that policy consideration could apply just as easily to an ambulatory practice. The other area that we're looking at is CMS has proposed the removal of several measures under promoting interoperability, specifically the ones that require patient action. So if we think of the view, download, transmit measure from meaningful use stage 2 or modified stage 2, there was a lot of disconcertation around that measure because it required the practice or the patient to take action, and it was the practice that was penalized or rewarded based on that action. So they proposed the removal of a lot of those measures, which will be interesting to see how then do providers adjust their strategies. And how does this really break out in terms of a scoring regimen like MIPS in the physician fee schedule, which is performance-driven and not threshold-driven? So there's a lot of open questions, but definitely thinking about what does it mean for me in terms of the new way I receive summaries of care, and what does it mean for me now that some of these patient engagement measures are gone, are the areas that I would really focus on.
We've heard so much about the opioid crisis and some of the measures now and CMS getting involved on that. What are they doing to take a stand against the opioid crisis?
So there are two things in this rule that pop out with respect to the opioid crisis, and it could apply in either an ambulatory or acute setting. So they're prescribing or they're recommending a measure around prescription drug monitoring programs, or PDMPs. So that is like a state registry or an immunization registry, but rather than reporting on vaccination statuses, right, you're reporting on Schedule II opioid prescriptions. The other thing they're looking at is a measure that would require verifying the existence of an opioid treatment agreement. We'll say with respect to PDMP, they are currently proposing that to be a voluntary measure next year, and they are proposing for it to be finalized in 2020, or be required in 2020. This is a challenging measure, though. PDMP, I think you're going to see a lot of variance in terms of how useful those registries are for providers and even for the respective governments, because they're all state-based. And whenever we have state-based registries, we see a lot of variance in different data element requirements, different testing and onboarding requirements, implementation requirements. And so getting those connections can be a little bit hairy. We saw this with immunization registries as well. I think with respect to the opioid crisis, the biggest action is now not on the regulatory front, but on the congressional front. So there's roughly 70 some odd bills that are moving through the House and the Senate at any given moment right now that are going through different committee markups. This is actually being done in a fairly bipartisan fashion. So I think we'll see the agencies take a little more action once they have some more direction and authority from Congress to do so.
And one of the other topics you touched on was removing quality measures, and what does that mean for providers?
So the answer is it depends. If you are in the acute space, what it means is you have to report on quality measures fewer times. So they've removed several quality measures from the promoting interoperability or meaningful use criteria for Part A. And that's because hospitals and other providers are already reporting on them through other programs. So why make them report on it through meaningful use? Now, quality measures is more than just a Part A problem, though, right? We've seen administrative burden be a major concern with respect to these measures because you have to code in order to make the numerators populate. Within the ambulatory space, I don't actually expect a removal of too many of them because they add more quality measures every year to give providers more choices for participation. I think what you might see is differences in how quality is scored. That might change. They may ask for people to report on a fewer number of measures, but the number of measures available for selection, I doubt, will decrease. The other area to keep an eye out on is they're engaged in this meaningful measures initiative where they're really trying to think through what are the right quality measure workflows. So the measure specifications themselves and how we get to those numerators may change. And that'll be something to pay attention to because it affects clinical workflow.
And as we're hard to believe already into June of 2018, what do we look forward to now in the second half of 2018?
I think the most significant thing to look out for, especially for our customers, will be the physician fee schedule. So this year they're going to take the physician fee schedule and they're going to combine it with the regulation for MACRA and MIPS. And they're kind of bolting those two together because it does make some sense, right? The physician fee schedule is about the reimbursable rates on Part B, and MIPS and MACRA are about payment adjustments based on quality and cost performance to Part B payments. That will be, I think, the most significant thing to look for. And then the other things I would look out for is in September, we'll see rulemaking around 21st century cures and information sharing, which statutorily has some possible provider overlaps. There are chances that they may tie things like federal incentive money to the exchange of electronic health record information through this 21st century rules making, and then expect most of these regulations to finalize in the late fall. So really important, I think, to get familiar with them early on so you have a stronger working base of knowledge when they're finalized and to operationalize the changes faster within your organization.
And is there anything providers can be doing now or taking steps to implement here in the coming months to prepare for 2019, or what should they be doing?
I think the most important thing is just to remain educated right now and keep abreast of it all. So this is going to be a really active rulemaking season, right? They've already said we're renaming meaningful use to promoting interoperability and changing these measures in all these different ways. That will somewhat require a re-examination of your pre-existing strategies for participation in these programs. And, if you wait until, say, November 1 when the rules are finalized, or, macro has to be finalized by November 1, to implement on January 1, that's a 2-month runway. That's not a tremendous amount of time. So just staying abreast on what they're doing, how they're changing it, why they're changing it, and then engaging with your EHR developer to see how they're going to manage those changes, and engaging with your providers early on what are the best workflows and measures for them out of the new programs, I think is really the most important thing. So really stay looped in and circulating information through your practice and your organization about what's coming to your key stakeholders, so that way you can operationalize a plan faster when the rules are actually final.
A little off topic now and away from regulatory issues. Of course, the summertime, a popular time for folks to take time out of the office, do some traveling, hopefully for our customers. That traveling includes coming up to Engage 2018 in National Harbor, Maryland from August 10th through the 13th. But David, while I have you, favorite trip or place that you've had an opportunity to visit?
Sure. Actually not a summer vacation, but a winter vacation. When I lived in China, I went to Harbin, or Harbin in Chinese. Harbin is a town or a city in northern China that borders with Russia. Very, very cool city. You see lots of blends of Chinese and Russian architecture, really great art. One of the neatest things is they build a giant ice festival, which is like a miniature theme park inside of the city. They had ice sculptures of the Great Wall, ice sculptures of beer bottles that were, I think, 20 stories tall, ice sculptures of different buildings. So really, really great experience and probably my most memorable vacation.
And the closest I've ever come to any ice sculptures is living in upstate New York for 36 years. So that sounds much more fun. And I thank David Heller, Corporate Counsel for Greenway Health Regulatory Affairs, for joining me on this episode of Putting Possibility into Practice. If you would like more information and to read more details about what we talked about on today's podcast, visit our Knowledge Center at www.greenwayhealth.com. We talked a little bit about it during this episode, but David has written a recent blog that touches on all the topics that we discussed today. So for more information, visit our Knowledge Center at www.greenwayhealth.com. I invite you to subscribe to our podcast on SoundCloud, on the Apple iTunes Store, or on Google Play Music. I thank you for listening to this episode of Putting Possibility into Practice. For David Heller, I'm Joe Augustinelli, the Social Media Manager at Greenway Health.